Hello, my name is John Kirby. I'm the Dean of the College of the Environment and Life Sciences, and it is my opportunity to introduce our speaker tonight. And it's an interesting opportunity in that we're going to hear a lot about health care. And I think if you go out and look at what Dr. Fine has done in his career, you'll notice that health care rises to the top of the conversation. I can tell you that he went to Case Western Reserve Medical School. And became an MD. He did his residency at Brown, did a National Medical Health Service funding to go to medical school, and ended up in eastern Tennessee in one of those places where health care is not a readily available commodity. Now, I think the interesting part of the conversation tonight, and I hope that you dive into this, is we're going to talk about health care not as a biological process necessarily, or all of the science component of healthcare, but healthcare as a societal and personal issue. And how do we see healthcare moving forward so that those of us who live here in Rhode Island and in the United States and in the world can gain access to healthcare and not just health insurance. Okay? Would you please join me in welcoming Dr. Michael Fine.
Good evening. Thank you all for being here, and thank you, Dean Kirby, for that kind introduction. What I'm going to say tonight started as something that I did in 1996, sitting at the table in a little practice that I started and worked at in Pawtucket on East Avenue. I was sitting there trying to figure out how to make a go of that practice as a business. And I was helping to negotiate contracts for a large organization of primary care physicians. And in order to negotiate those contracts, I had to figure out for the first time what it cost us to deliver health care, to deliver primary care to everyone that we took care of. At that point, we took care of about 4,000 people, and the math to figure out what it cost was actually pretty simple. The amount of money it cost to run the practice, including our salaries, divided by the number of people we took care of. And the number I got shocked me. It shocked me so much I redid the math 3 or 4 times to make sure I got the decimal place right. What I found out was to deliver primary care, which for us was being on call 24 hours a day, 7 days a week, seeing people when they were sick, in those years going to the hospital to take care of them when they were sick, doing physical exams, doing sports physicals, taking phone calls from moms at 3 o'clock in the morning. The per person, per year cost of the primary care we delivered was $106. A number so small that I looked at it and couldn't believe it, because in those years, the per person per year cost of health insurance was $4,000. Now I knew, because I had had a little bit of health policy training, that the value of health insurance was really deeply vested in primary care. Most of the value of health insurance comes from primary care. And we were paying $4,000 to get $106 worth of value. And that started what for me was kind of a personal journey. It was one of those eureka moments that made me say to myself, well, if it's this inexpensive and this effective, why aren't we giving it away? So that started me on a journey that brought me to this stage tonight talking to you. I've got a lot of data to present, and please forgive me, I did a 50-minute talk that I'm going to try to do in 35 minutes. So hang with me, we're going to go pretty quick. It's going to be a little wild, and I hope it's going to be a little fun. And by the time we're done, I think we're going to have a different way of seeing what purports to be a healthcare system, but is just a healthcare market. Now, one of the things I did, since I agreed to do this talk, was I changed its topic, or its title. I'm going to talk about the same things. What I'm really going to talk about is how the healthcare market is at war with health itself. The boiling frogs, the three pipers, the primrose path, the drinking gourd, Magellan ships, and the yellow brick road are all analogies I'm going to try to use to make things clearer. But what I'm hoping to convince you of is that Rhode Island can, in fact, improve health, reduce cost, restore our economy, and we can do it before any other state in the country. And for those of you who are from Rhode Island, I think we can do it without packing a lunch. Thanks to the people who helped me put this talk together. Lots of help with lots of friends and lots of teachers, though the responsibility for the accuracy of the information and the assemblage of this information is mine alone. I'm going to be talking about how healthcare is crippling the nation's economy. I'm going to be telling you that medical care doesn't matter much for health. But what matters most for health is actually human services spending. And because we're spending money on medical care, we don't have enough money left over to spend on human services, and that's making health unachievable and unattainable. I'm going to be explaining how primary care can reduce healthcare costs and leave us some money left over to spend on education, housing, public safety, and the environment. I'm going to be explaining that primary care is really the only medical service that significantly impacts population health. And then I'm going to be telling you, really for the first time publicly in Rhode Island, about how a primary care trust can bring primary care to all Rhode Islanders and build a healthcare system in Rhode Island and in this nation for the first time. So let me tell you about the boiling frog. I don't know if you've all heard the famous story of the boiling frog. It's pretty simple. If you put a frog, they say, in a pot of boiling water, the frog figures that it's hot and hops out. If you put a frog in a pot of lukewarm water and turn up the heat rises gradually. The frog begins to warm up and gets comfortable, gets really comfortable, and when the water starts to boil, the frog doesn't react and boils to death. That's the situation in the United States. Our health care expenses have gone through the roof over the last 50 years. By 2032, the projected annual family health insurance premium cost will be greater than the average household income in the United States. By 2025, we get greater than 50%, but by 2032, it's greater than the entire earnings of a family. That's not sustainable. We spend money on lots of different things, on physicians and hospital care and on prescription drugs, lots of different things, all of which are getting more expensive every year. Getting more expensive is at a rate that's 2 to 3 times the average rate of inflation itself. So we are seeing cost increases of 6 to 10% a year, and have seen an average cost increase of about 6.5% for the last 20 years, which is why our economy is in shambles. The United States spends as much as other countries on human services, but most of our spending is on the healthcare portion of the human services. If you see the United States in red, you see the light blue line as rather large, and the rest of human services as rather small. And as I'll explain in a few minutes, it's the rest of human services that matter for population health outcomes. The medical care that we're spending money on doesn't, and that's where part of our pain is. We spend more per person per year on health care than Japan and the United Kingdom combined. Healthcare costs add more than $1,500 to the price of every General Motors vehicle. The company spent $4.6 billion on healthcare in 2007, right before it went bankrupt. And guess what? Then it went bankrupt. Because of these costs, American businesses are losing their ability to compete in the global marketplace. Healthcare at General Motors just put it at a $5 billion a year disadvantage against Toyota, which spends $1,400 less on healthcare per vehicle, not per person, per vehicle. So Toyota has a $1,400 price advantage on every car they make, and that process is duplicated with everything that's made in the United States. My across the street neighbor is a plumber who has to pay for his own health insurance, and he told me that it costs him $10 an hour, $10 an hour, a working hour just for health insurance. Imagine that, more than the minimum wage. Somebody way smarter than I, Peter Orszag, who ran the White House Office of Management and Budget, said that the United States standing in the world depends on its success constraining the healthcare cost explosion. Unless we can constrain that cost explosion, the country will eventually face another fiscal crisis or a crippling inability to invest in other areas. And he said that in 2011, after the last healthcare crisis, which arguably was likely caused, at least in part, by our healthcare expense. Healthcare is, or the cost of healthcare is swallowing the rest of the things that we spend money on. And when you really look at the United States healthcare market, and I use the word market intentionally because in the United States we have a healthcare market and not a healthcare system. We are overpriced by a factor of 2. We waste between $600 and $850 billion every year on unnecessary, dangerous, or fraudulent healthcare expense. If you look at our ranking compared to other countries in the world, though we're paying twice as much, we rank at 37th in the world. That's a little like going to the store to buy a dozen eggs, seeing a sign that says the dozen eggs is $1, going to the checkout counter, getting charged $2, and then noticing that half the eggs are broken. We leave out almost 50 million people a year now, and our healthcare system kills 100,000 people a year by accident. We are cannibalizing the rest of our social services, and we have not even provided universal access even to primary care. If you take a step backward, our market has no clear mission other than profit for investors. We are suffering from a for-profit system in a world that most of us want to be nonprofit, a service that most of us want just to trust. Here's how we waste money. I'm not going to detail each potential cause, but I want you to look at the bottom one, unwarranted or unnecessary use. $250 to $325 billion a year in expense that is unhelpful or unnecessary. Just we didn't need to do it. Many of you heard about the meningitis outbreak, the recent meningitis outbreak related to epidural steroids. 14,000 people had gotten epidural steroids in a 3-month period in the United States. There is no evidence that epidural steroids are any more effective than doing nothing. We exposed 14,000 people at a cost of many millions, if not billions of dollars, to an incredibly invasive procedure with no evidence that it's any better than just watching and waiting. When you look at the proportion of Medicare spending attributed to each category of care, if you break care down by preference-sensitive care, that means what people might want. I want an MRI because it's Tuesday. That's preference-sensitive care. To supply-sensitive care, we have lots more hospitals, so lots of people use hospitals. Or to effective care. John Wenberg, probably the nation's premier health services researcher, found that 12% of the care we deliver is effective care. Now that doesn't mean the others are necessarily ineffective, but what we know is that the evidence supporting their use is weak to none. And here's the part that's most painful. Despite all our spending, only 10% of population health outcomes are due to medical care. And I want you to think about all categories, the behavioral patterns and genetic predisposition and social circumstances. Medical care, despite 86% or more of our spending being on medical care, it delivers only 10% of the outcome improvements. Turns out that the major determinants of population health aren't medical at all. At the end of the day, they're social, what we call social determinants or social measures. Those include smoking and environmental exposures, income, equality or inequality, race as a marker for the impact of racism on the measured health outcomes of individuals, and the one medical service that turns out to matter in terms of population health outcomes is what's called primary care supply, the number of primary care physicians per 10,000 population. I'm going to explain why that works in a little bit, and I actually have to thank you all for inviting me here tonight. I've known about this association for many years, but in preparing this talk, I got to understand it for the first time, and I hope I'm going to be able to explain it to you. Healthcare has just failed to deliver health. 86% or more of our healthcare spending is on medical services that really don't matter. And again, 90% of health outcomes are produced by education, housing, environment, behavior, genetics, and social organization. Rhode Island, our little state, spends way too much on health care. We are 22% higher than the national average. In 2011, the cost of family health insurance through an employer was about $15,000. At the same time, in 2011, the average annual wage for an employee of a private company in Rhode Island was $45,000. A third of effective income is being spent on health care now. 2025, it becomes half. 2032, it's everything. And it's everything for a service that probably doesn't deliver health. If Rhode Island had simply kept Medicaid spending from increasing, just Medicaid is one small slice of what we spend, about $400 million a year if my memory's right. If we'd simply kept Medicaid spending from increasing between 2010 to 2011, the projected savings for the state would have been $26 million, which is equivalent to the salaries of about 686 new teachers. That's 2 new teachers for every school in Rhode Island. One of the things that got me thinking about all this as well is I live in Scituate, and I go to the Scituate Town Meeting every year. And every year, what I see is that the cost of health insurance for teachers goes up, and the services we provide to our kids goes down. One year we lost the late buses. One year we lost the music program. And we lost these things to subsidize health insurance to buy a service that doesn't really matter. So in 2010, we spent $709 million of state dollars on Medicaid. When you add in the federal contribution, that is $1.9 billion that we spent on Medicaid alone. At the same time, we spent $250 million on health insurance for state employees and another $168 million for municipal employees. So our grand total spend of tax dollars is about $2.5 billion a year, pretty much evenly split between state tax dollars and federal tax dollars. But though the governor likes it when we don't spend so much state tax dollars, you and I know something, the governor knows it too, that whenever we spend tax dollars, we spend everybody's tax dollars, whether it comes through the federal government or through the state government. That's a tax on all Americans, and it's an income tax. What this is doing is reducing everybody's tax every day of the week, every week of the month, every month of the year. The total health care expenditure in Rhode Island in 2009, 3 years ago, was $8.8 billion, which is a little larger than the entire state budget. That's the total spend, not only with state dollars, but including commercial health insurance as well, and Medicare. As I said before, the average annual growth in healthcare expenditures is about 6.3%. We estimate that healthcare costs in Rhode Island rose by $553 million from 2009 to 2010. That's equivalent to the salaries of 14,477 new teachers in Rhode Island. 14,477 new teachers is more than the total population of Scituate. If we waste, instead of just look at cost inflation, it turns out that most experts' estimates are correct. If we waste $30,000, then we're wasting about $2.5 billion a year, which could fund a tax reduction or a reduction in the cost of health insurance. If we reduce the cost of health insurance, we bring new businesses into Rhode Island, and that's what we need to do to restart our economy. We could also pay for many more new teachers, lots of new housing, and for those of us who are old Rhode Islanders, we'd even get some of the roads fixed. And to top it off, because we're spending money in the wrong place, we die soon. We spend twice what other industrialized countries spend, and we have a shorter life expectancy. Our infant mortality rate is more than twice the rate of countries that spend far less. Healthcare in Rhode Island has some successes, but it's still an economic drain. We have the best immunization rates in the United States. We have really good control of infectious diseases, with a fair amount of support from the University of Rhode Island. We have made real progress with smoking rates. We're down to between 15 and 20% of Rhode Islanders smoking, from 40 to 50%. And though we have issues, big substance abuse issues with obesity, cancer, and heart disease, but regardless of how good we are, healthcare still consumes $2.5 billion a year of public spending, and again, a third of which is wasted. And here's the thing that I learned most about. We did a bunch of projections. And when I looked at these projections, it made me sick. We have 1,200 unnecessary deaths a year from heart disease and stroke because we have 80,000 Rhode Islanders who have untreated blood pressure. We have 64,000 Rhode Islanders who have inadequately treated blood pressure. We have 32,000 Rhode Islanders with undiagnosed and untreated diabetes, and another 15,000 Rhode Islanders with inadequately treated diabetes, and those folks are all going to get heart disease or strokes or some complication if we don't do something about it. We have 200 unnecessary deaths from colon cancer, which is a preventable disease, and 200 drug-related deaths a year from drug overdoses, 2/3 of which are from prescription overdoses. 2/3 of those deaths, or about 130 deaths a year, are deaths to people whose prescriptions were written by a Rhode Island physician or nurse practitioner and dispensed by a Rhode Island pharmacist. We have 100 to 200 unnecessary deaths and 300 to 400 unnecessary hospitalizations from influenza. And we have 600,000 Rhode Islanders who are not vaccinated every year against flu. We have 100 unnecessary new cases of HIV or AIDS a year, a now preventable disease. And that's with one of the best healthcare systems in the country. These are all the people who we've left out. So let me tell you about the three pipers. I'm old. When I was growing up, we used to talk a lot about the Pied Piper of Hamelin. You may remember that story. For those of you who don't, the Pied Piper was a piper. He played the pipes of some sort, probably the Aeolian pipes, if we're lucky. I like the Aeolian pipes. But the people of Hamelin was infested with rats, which in those years carried bubonic plague, so they were interested in public health. And they didn't know what to do about their rats, so they got the Pied Piper to come. He said, "Gee whiz, if you let me pipe, I will pipe the rats out of town, and you just have to pay me." And they said, "Okay." So he piped, and the rats followed him out of town, and he took them to the river, and they ran off a bridge and all drowned. So he came back and said, "Okay, now it's time for you to pay me." And he said, and the townspeople said, well, they would have followed you anyway, or they would have left anyway. Maybe not. So he said, okay, you're not going to pay me? And he piped again. And this time, the town's children followed him out of town. The story of the Pied Piper is the story of what's been besetting us and why all this is happening. There are 3 pipers. One is marketing. Look at what is spent on different kinds of marketing. And there are different estimates, and these estimates, I'm sure, are not perfect, but they're not too terribly far off. Billions of dollars are being spent on marketing, pharmaceuticals, tobacco, food. Why do you think we have obesity in the United States? Pornography, hospitals. We spend $1.5 billion a year marketing hospital services, while the total budget for the Centers of Disease Control and Prevention, that's CDC, which not only does some marketing, probably a couple $100 million a year at most, the total budget for CDC, which includes its international health work and its vaccine development and a whole bunch of important programs, is about $11 billion. We outclass CDC by probably a factor of 7 or 8 in terms of what we spend on marketing, what we spend on getting people to do exactly what we don't want them to do. Then we have something in the United States called the medical industrial complex. This was described by the editor of the New England Journal in the early 80s, Dr. Arnold Relman. And he really described a world in which there was this inappropriate overlapping relationship between academic medicine, research, pharma, and medical device manufacturers, and there was a revolving door. People would go from one to the other, and as they went from one to the other, they would make recommendations that were designed to enrich somebody, even though they were also cloaked with the garb of improving people's health. And as you can see, we haven't done a great job at that. That has really influenced the choices of medical students and others about whether to go and do primary care, which is what we really need. The United States specialty to primary care ratio is about 70 to 30. We need 50 to 50 or more of our physicians to be primary care physicians. And that's all off recommendations that come from academic medical centers who treat just 1% of the United States population. So second piper, medical industrial complex. Third turns out to be health insurance. Initially, it was used as a means to promote access to health services in a nation without a healthcare system, but it's got a huge unintended side effect. It removes what people call skin in the game. Once you have a health insurance card, you don't pay much attention to what things cost because you don't have to. And once that happens, everybody with something to sell is out there cashing in. People with health insurance don't discriminate that well between needed and unnecessary services. And so we have billions of dollars, like $800 billion, being spent on unnecessary services. Our products and our marketing, thus, cause our illnesses. Think about cigarettes. Everybody knows about cigarettes. Think about cars how they're related to reduced exercise and their environmental impact. When was the last time anybody here cranked down the window in their car? We've designed them to make it so that you don't have to work. When you don't have to work, you don't burn calories. When you don't burn calories, you get extra weight, etc., etc. The United States government in 1985 started subsidizing the growth of corn, and the production of high fructose corn syrup has been clearly and directly related to obesity, diabetes, high blood pressure, and heart disease. We did that, and we did that to ourselves. We keep inventing labor-saving devices, from electric toothbrushes to electric razors, all stuff that we can do ourselves. And, you can see I don't shave very much, and I certainly don't need much in the way of haircuts. But all those labor-saving devices take away a little bit of exercise that everyone gets. In 1969, about 90% of the population, 90% of school children walked to school. In recent years, that number is about 10%. Hospitals and pharmaceuticals, again, many deaths from errors. many more known side effects and adverse reactions, just side effects of, predictable side effects that aren't ARAS. So we probably kill more people than that. Popular culture often contributes to depression, anxiety, sexually transmitted disease, and adolescent pregnancy. And suburban sprawl really contributes to isolation and depression. And remember, in my lifetime, depression, which sometimes for some people might be called sadness, has now become, or alienation, has now become a diagnosable, treatable disease. That doesn't mean that it's not a real disease, but I often think, gee whiz, let's take a step back and think about what we're doing and how we're doing it. Some people have said that attention deficit disorder, which is widely overdiagnosed, might also be called societal contraction disorder. Once upon a time, we had a fidgety kid and had them look out the window and it was okay. We have become intolerant of fidgety kids, and we've tried to force every square peg into a round hole and used medication to get them there. So healthcare reform is going to fix this, right? Well, you know the story of the Primrose Path. So here's what we're going to get. We're going to get healthcare market reforms, which is a good thing. Nobody is going to be able to be refused health insurance if they can pay for it. We're going to get a weak insurance mandate, which is going to force some people to buy insurance, but some people, because the mandate has a relatively low fee associated with it, some people will choose to spend $900 and take what the Supreme Court now calls a tax, instead of spending $15,000 on family health insurance. More people are insured now, but there are going to be 20 million people left out in 2014, 23 million left out in 2019, and probably about 30 million left out by 2025. We're going to get some Medicaid expansion, which is a good thing, and subsidies for lower-income Americans. We didn't get a public plan. We got insurance purchasing exchanges, which are going to be at least interesting. We put $12 billion into community health centers, which is a very good thing. And we got lower Medicare cost growth, but not that much lower. But what we'll also get is continued cost growth. Most people expect healthcare cost inflation to still be 5 or 10% a year, at least in the near term, so that even with healthcare reform, we expect healthcare to rise from 17% of the gross domestic product now to 25% of gross domestic product by 2025. We can't say with any certainty that we're going to get predictable improvements in population health with all the money we're going to put into healthcare reform. We certainly don't have a clear mechanism to see change or worsening, any change or worsening in income, change in the worsening income inequality. We don't know if there's going to be any change in health disparities, but no great reason to think there's going to be. We don't have any reason to think there's going to be a predictable change in reading level at 4th grade, which really predicts life expectancy, though there may be. And we don't know how healthcare reform will affect social cohesion and civic trust, which is what a lot of people mean by health. We may get some improvements, but no certain improvements, and we don't know how our spending is going to correlate with those improvements. But what we will get is a health insurance and medical service marketplace that is still for profit. And the other thing that healthcare reform left out is we won't get a healthcare system, a healthcare delivery system. As I said, healthcare remains a for-profit business. No controls on industry's ability to impact the legislative process, so that at the end of the day, we probably fed the fox and left the fox in control of the marketplace. I'm going to skip over this just for a second. Let me talk about the drinking gourd. The drinking gourd is a famous story from the Underground Railroad. Freed slaves used to look up in the sky at the Big Dipper and follow the Big Dipper north to get to Canada. And I think for us, the drinking gourd turns out to be primary care. Primary care is associated with lower costs and better health outcomes. Gave you a list of all the different kinds of primary care professionals from family physicians to internists to pediatricians to nurse practitioners and pharmacists, a whole bunch of people who all provide first contact care in the communities where they work. Primary care practices. Well, in Rhode Island, we have lots of people who practice in onesies and twosies just by themselves or with one or two other people. But we have a bunch of larger multi-professional primary care groups. We have more patient-centered medical homes than any other state in the country. That's a business-sponsored process to standard and improve primary care. And we have a good network of community health centers which serve between 10 and 15% of Rhode Islanders. The way we think about primary care, we think about primary care supply, how many primary care physicians per 10,000 population. We think about primary care architecture, how primary care practices look, whether they're open from 8 o'clock in the morning to 8 at night, whether they're open on weekends, what kind of health professionals are there. And we think about what it takes to get primary care physicians, to get people to use primary care practices. Now the cost piece, the piece I talked about in the beginning, is still real. We spend $8,000 per person per year on health insurance. We spend between $800 and $1,600 per person per year just on running the health insurance companies, but we only spend $300 to $400 per person per year on primary care. But primary care is really what produces outcomes. So this is what happens in countries that have good primary care. We get less premature mortality. In countries with good primary care, we have lower cost. In countries with good primary care, we have better health care quality. There's lots of evidence linking primary care to better outcomes and lower cost. So I just thought I'd picture some of the evidence, and there's a little more evidence, and there's a little more evidence, and I could go on and on and on. There is bukus of evidence, and somehow we've looked at it in the face for the last 20 years, and we haven't done anything yet. A couple of us did a thought experiment about 3 years ago and said, what would it be like if we could take everybody in the country and have their primary care supply, the number of primary care physicians per 10,000 population, have the same number of primary care physicians as the best states in the country, the 5 best states. What would happen to heart disease mortality? Well, again, this is the warning about this is a professional driver on a closed course. These are estimates and projections, so please accept that as a disclosure. The scientific value of this is probably limited. But these are projections that actually turn out to match up with some other stuff CDC has done. So if we got primary care supply for the whole country, what it is in the best states, we probably have 102,000 less deaths a year from heart disease. We probably have 37,000 fewer deaths a year from infant mortality. We probably have 6,000 fewer deaths a year from stroke, and 2,700 fewer deaths a year from diabetes, and 6,000 fewer deaths a year from cancer, which is about twice the yearly improvement we now experience with all our other cancer interventions combined. We would likely lengthen life expectancy by 1 full year, a greater improvement than occurred during the years 2000 to 2006, a time during which we spent more than $2 trillion a year, or a total of $8 trillion on health services. That all adds up to about 150,000 lives a year saved. And when you drill it down to Rhode Island, that's 500 Rhode Islanders. Now, for a long time, I thought that was specious. Somebody got the Colloquium piece. A long time, I thought that was specious. But recent numbers from CDC have suggested that if we could just diagnose and treat all high blood pressure, diagnose and treat effectively all diabetes, and get everybody's cholesterol to where it ought to be, that we'd save 1,200 lives a year in Rhode Island. So I think these numbers, wild projections that they are, I think they're real. Now, what happens to cost when you make primary care in the whole country the same as the 5 best states now? Hold on to your seats. This is a really complicated slide, and I'll try to make it as simple as I can. If you expand health insurance to everybody in the country, but don't change primary care supply, you get somewhere between 125 and $250 billion a year in new cost. However, if you bring everybody in, what we did with healthcare reform, improve primary care supply and leave the system as it is, we get $45 billion a year in new savings. And if we do better than that, if we play around with primary care architecture and make all primary care practices look like community health centers, we get as much as $253 billion a year in new savings. Remember, all cost projections, and the scientific validity can be argued, but the drift is pretty clear. And in general, that's just by pushing on primary care supply. Just imagine what would happen if we added multidisciplinary teams, open access, that means you're sick today, you're seen today, extended hours, neighborhood outreach, that means having health workers be able to get into every neighborhood, know every street, and know every person. Home health, mental and behavioral health, substance abuse prevention, an integrated electronic medical record, really robust primary care practices, one for every community. Just imagine that. And here's how it works and why it works. It works pretty clearly because of the chart I showed you before. Primary care, though a tiny slice of our healthcare expenditure and of our healthcare market, primary care practices work with people to help them change their behaviors and to help them mitigate for the risks created by their genetic predisposition. Counseling changes behaviors, and if you don't know, the reason we know that is something that came from URI. Dr. Prochaska has taught us all how to think about that. Primary care mitigates the impact of genetics, and that's before we put all that saved money to use, improving education, improving housing, improving public safety, and improving the environment. Primary care reduces cost by expanding access to the right place, right time, and right size services. Translated into English, basically that means that if there are lots of primary care doctors around and lots of good primary care practices that are open from 8 o'clock in the morning to 8 at night and open on weekends, then people go to the primary care practices instead of going to the emergency room, and emergency room costs 50% less than, or people use emergency rooms 50% less than they do now, and that leads to a 25% or more decrease in hospital utilization. And these numbers, which sound wild, turn out to happen over and over and over again. I just looked at a study of the VA in Providence that did something like this at our VA and reduced emergency room utilization by, I think, 63 or 64%, and reduced hospitalization by over 30%. Primary care, the way it really works is it spreads the value of prevention, which does work, to more or maybe to all Americans or all Rhode Islanders. When everybody has primary care, then everybody with diabetes and high blood pressure is identified and their complications can be prevented. Almost everybody who might get colon cancer has it prevented by getting a colonoscopy. Almost everybody who might get cervical cancer has it prevented by getting pap smears, and many more people who might get breast cancer have it prevented by mammography. Everybody with HIV is tested, identified, and treated, and then they can't transmit HIV, and dear to my heart, everybody gets a flu shot. I hope everybody has had a flu shot. So I don't know if you've ever heard the story of Magellan ships. Anybody heard the story of Magellan ships? Actually, it's an apocryphal story, and I have to disclose that in advance. Something like it probably happened to Captain Cook off Australia, but I like telling it about Magellan because it's a more poetic kind of language. So Magellan is trying to sail around Tierra del Fuego, and he's running out of water. So he sees some cooking fires, and he sends a landing party. And people in the landing party look around, and all of a sudden, a bunch of native people with spears jump up, and they say, "Come with us." and they take them to a big fire where the sachem is standing with the shaman, and they think they're going to get boiled alive. And so it turns out that one of them speaks Portuguese, so they talk a little bit back and forth, and they explain that they're just here looking for water, and the sachem says, no problem, we're going to give you all the water you need, but, we're kind of interested in something. We've never seen you before. Where'd you come from? And so Magellan said, well, we kind of came from Europe. There's a big ocean out there. We came over the ocean. And I said, oh, that's really interesting. We don't know anything about Europe, but now tell us, how did you get here? And so Magellan says, well, we came on our ships. And the sachem says, ships? What ships? And so Magellan says, right there, right in the harbor, those ships. And the sachem says, I don't see any ships. And he looks at the shaman. And the shaman says, I don't see any ships. These guys must be crazy. And all of a sudden the spears start to raise again. And Magellan's getting a little nervous. So he says, okay, well, I'll tell you what. We get in our boats, you get in your boats. We'll go out to the ships. We'll show you the ships. So Magellan's guys get in his boats, and the native folks get in their canoes. And they go out to the ships, and they throw down the rope ladders, and everybody walks up and climbs up the rope ladders. And then Magellan says to the sachem and the shaman, he says, he stamps on the ground. He said, these ships. And the sachem says, oh, these ships. These are ships. We never saw any ships before. We didn't recognize them when we saw them. And that's our problem. We've never seen a healthcare system in Rhode Island, and we've never seen a healthcare system in the United States. We've only seen a market. I wrote a definition of a healthcare system, which I won't bore you by reading, but you can imagine what a healthcare system might look like now that I told you that there is such a thing. So take a minute with me and imagine a healthcare system. To me, a healthcare system is one primary care center for every community of 10,000 people that is a mile or two from everybody's house, that has many different kinds of health professionals, that's open again from 8 o'clock in the morning till 8 at night and open on weekends, and provides 90% of the health services the community needs, and does it in a way that 90% of the people in each community want to use that healthcare center. That's a healthcare system. And that's the Yellow Brick Road. That's how we get to Oz. And the way we build it is by building what we call a primary care trust. A primary care trust is a financing mechanism that will let us build this system in Rhode Island. We estimate we need 70 to 75 of these health centers, and we ought to put one in every community of 10,000 people. And guess what? We can afford to do it today. We could have afforded it yesterday. And if we do it, we will save millions, if not billions, of dollars. It's built around a single payer system, but just for primary care, and leaves the rest of the healthcare market, specialists, hospitals, and the health insurance system, such as it is, intact. It organizes and simplifies primary care payment, so the primary care practices are paid to deliver health care to communities in addition to delivering sick care to individuals. As I said, it builds primary care practices in each Rhode Island community, which is really building on our existing primary care practices and on community health centers. The practices can just as well be run by private enterprise, not government. But at the end of the day, it's a not-for-profit healthcare system, not a for healthcare system, and it preserves patient choice, I can tell you how, and guaranteed no death panels. And what do we get out of that? We get improved health outcomes. We markedly reduce cost, assuming we can get rid of the unnecessary care and finally put prevention to work. We build local economies and communities. Each of these primary care centers is a $20 to $30 million a year business. And let me tell you, you put one of those businesses in 75 Rhode Island communities, and all of a sudden, those communities have economic engines in the middle of them. It provides most medical services people need. It's accessible and affordable. It promotes relationships, which is what most people mean by health. And it's a healthcare system. Once everybody is in, if we build it today, tomorrow we have the first healthcare system in the United States. So, as I said, healthcare is crippling the nation's economy. medical care turns out not to matter much for health, but human services spending does. So medical care is what's making health unachievable and unaffordable, but primary care can reduce healthcare costs and leave us money to spend on education, housing, public safety, and the environment. Primary care, remember, is the only medical service that significantly impacts population health, and a primary care trust can bring primary care to all Rhode Islanders. Bernie Lound, who won the Nobel Prize in 1985, the Nobel Peace Prize, for his work with International Physicians for the Prevention of Nuclear War, and is a world-renowned cardiologist who taught us all lots about various arrhythmias and actually has a disease named after him. Bernie says, if you see the invisible, you can do the impossible. I hope tonight I've shown you something that some people think is invisible, and I hope you agree with me that it is by no means impossible. Thank you. So now I think I'm going to respond to some questions.
As the director of the Rhode Island Department of Health, what do you see as the biggest healthcare problem in the state, and what do you see as the most important health concern in the country?
The cost of healthcare, because what we're spending on healthcare means we don't have money to actually spend on the things that matter for health. You weren't expecting a short answer to that.
Sure. The next question is, what changes do you think need to be made, I think you outlined this, that all Rhode Islanders will gain access to the medical attention that they need?
Well, we have to build this network of 70 to 75 health centers. That's the biggest change. But when we do that, you're going to see a couple of things happen. The number of hospitals is going to shrink. It's shrinking already. We're seeing a 10, 15, 20% reduction in hospital beds, 10% in the last couple of years, and that's going to really stress the hospital sector. So we're going to see a whole different hospital environment in Rhode Island than we saw before. We're going to see many medical services move into communities where they should have been all along.
The next question is, what are the 5 best states for primary care, and why are they the best?
Well, it's hard to answer who's the best state for primary care. It turns out, actually, we are one of the best states. But that doesn't mean that we're anywhere near where we need to be. You know, again, we measure primary care supply, the number of primary care physicians per 10,000 population. We're number 4. We measure something called the number of primary care practices that are patient-centered medical homes, which is a lot of jargon for saying practices that pay attention to the patients they take care of and pay attention to the populations they take care of. We're number 1 in the nation for that. But that doesn't mean that we don't need, and we're going to be sharing some evidence over the next month or two, we don't need a couple of hundred, probably 200 to 250 more primary care physicians to get the best outcomes and help us have the lowest cost. So I would put us near the top. Other places are places like Utah and places that have accountable care organizations. I mean, classically, supply is Utah, Vermont, Alaska, and I think Maine. But I think we're better than all.
Interesting question. Why doesn't the U.S. make health insurance companies nonprofit?
Well, I'm going to turn that right back at you all. It's because we haven't made it. I don't know if you really want to make health insurance companies nonprofit. You might want to shrink them some and make the system itself nonprofit. And we might want to do something about healthcare profiteering. You know, one thing that most people don't know is that many nonprofit healthcare facilities and health insurance companies, they may be nonprofit on paper, but they pay their executives millions of dollars a year. That is not my definition of nonprofit. So it's not just nonprofit, it's nonprofit plus being reasonable and making sure that that they spend the money they earn on what Rhode Islanders and Americans need.
If you could make 2 changes to the Patient Protection and Affordable Care Act, what would they be?
Well, I don't think we need to change the act much. I think we just need to add primary care for all Americans. If we built this system of 75 primary care centers in Rhode Island and then built it across the United States, that's what we need to get accomplished. I think we estimated we need about 15,000 of them across the United States. And it saves us money. It doesn't cost us money. So if I could augment the Accountable Care Act, and let me tell you, I did a fair amount of work trying to get them to do it. If I could augment it, that's what I'd do. I'd make sure we had primary care for all Americans. And if we can't get primary care for all Americans, then we ought to get primary care for all Rhode Islanders, and we ought to do it tomorrow.
Well, here's an interesting question. How open to building the 70 to 75 health centers are Rhode Island's primary care physicians? Are they open to closing their practices and working out of the center?
Well, we don't know yet, but I actually would challenge some of the assumptions. I think many of those primary care physicians are already practicing in practices that can become those primary care centers. I don't think anybody much has to close a practice. And the art of doing this is not to push anybody around. The art of doing this is to let people practice the way they practice, but add these primary care centers and let's grow our existing practices. We have 11 community health centers. We have probably another 5 or 10 pretty close to full-size practices, and I've showed you the names of some. The Bristol County Medical Center for me is the archetype of how to do this and do this right. So as we change our reimbursement strategy, I think many people will choose to work in one of these practices. But I think everybody contributes, and we ought to let everybody who's practicing on their own and wants to keep doing that, I think we ought to let them stay, but we ought to let them experience the joy of the fee-for-service system and the insurance companies, which have enslaved them for the last 20 or 30 years and wrecked their lives.
On a different note, would patients be satisfied with being told that they don't need treatment for their illness, or are we acculturated to believing that treatment is necessary to get better?
We are definitely acculturated, but it's to believing that it's way easier to do something than to do nothing. But that acculturation, as the questioner asks, is marketing, not acculturation. Somebody's spending millions and billions of dollars to get us to think that way, and they're only spending that millions and billions of dollars because they're making a profit on us thinking that way.
So with this grand plan, how will we pay the people working in the primary care centers to match the cost of their high-cost medical or health professional education?
The easy answer to that question is better. But I think we have to do more than that. I think we have to find a way to subsidize the medical educations or the nursing educations of people who are going to work in primary care. Either subsidize it or make it free, but have it come with an obligation so that they stay and work in exchange for the educational support they took. That's my personal experience. The dean mentioned that I spent 3 years in the mountains of East Tennessee, and I did that because the government paid for me to go to medical school, and it was an honor to do that. I stopped thinking that the medical education I got was mine, and instead I thought the medical education, and still think the medical education that I got was like a public utility. This is everybody's medical education, and so my obligation is to use it in ways that take care of everybody. And boy, do I wish that we had 50,000 doctors and nurses in Rhode Island who felt the same way. The reason people come out the way they come out, we've designed a system to make them feel this way, to make them feel trapped and entrained, and like the only possession they have is their medical education or their nursing education or their pharmacy education. And I think shame on us. We can do it better. And once we do it better, we set them free.
Okay. All right. What are the first 3 steps I'm sure there's many more steps that need to be taken in Rhode Island to achieve your plan, and who takes the lead?
The first step was tonight. And I mean that seriously. The first step was to lay this out and let people start to talk about it and debate it and see if they think we're right. We're going to have to build a lot of support for a change like this. And I think the first step is talking to you and asking all of you to talk to people you know and start to talk and debate. And I think that when you talk and debate and look at the numbers that we look at, I think you'll end up with the same conclusion. And then the next step is for us to start to talk to our legislators and see if they think we're right too. We have a system of checks and balances. What did Churchill say about democracy? It's the worst form of government except for all the other ones. It's not easy, it's not simple, and it's not direct, but it lets us test ideas and debate them, discuss them, and arrive at what's usually the right conclusion. As Churchill also said, I think this was up on a slide, Churchill also said, the Americans, you usually get the right answer after you've tried all the other ones. And so, I think the second step is lots of debate and lots of discussion and hopefully some action. And then the third step is to build it. We have the basic elements in place. We're already paying for it, and we're actually paying for it through the nose. So we might as well just build it and give primary care away and make sure all Rhode Islanders have it, and then we get a healthcare system. Made it sound a little too easy. It's a little more complicated than that. But I think the journey of 1,000 steps started here tonight.
On a different tack, perhaps, what are your top priorities regarding the obesity epidemic facing our nation and Rhode Island? Do you think that familiarizing children with farm to table will help negate the effects of our fast food nation?
What a great question. The first priority in figuring out the obesity epidemic is to help people figure out how to eat less and not be pushed by food marketing. I actually wrote a book called The Zero-Calorie Diet that kind of lays out some of the ideas. It just turns out that you don't have to eat very much, and it's a bummer because food tastes good. But we have to help people understand that, and we have to create the right kind of incentive so people make the right choice. Some people have talked about taxing sugar-sweetened beverages. Most Americans aren't really enthusiastic about new taxes. We do a little talking about whether we should be labeling beverages or food as toxic if they are, like the way we label cigarettes, or putting up signs in stores that sell food products. We don't have enough evidence, and we don't know what the right answer is yet. So, probably the first priority is research to figure out what works. Familiarizing children with farm to table, developing as a state, developing our local farms is a critical piece of this because it's a critical way to build our economy. And then having kids involved with those farms is a phenomenal idea. That doesn't mean it's easy, simple, or quick, but I think it's going to help, and I think we ought to do one thing. I am tired, from a public health perspective, of walking around and saying, you got to do what we say or your body parts are going to drop off. I want us to be saying, good stuff, like, drink water from a cup, drink water from a pitcher, not don't drink sugar-sweetened beverages. Everybody knows not to drink sugar-sweetened beverages. Turns out that tap water is 1,900 times less expensive than bottled water. But to go back to the primary care trust, I figure if somebody can sell a bottle, if somebody can sell water in a bottle, can sell something that's free and healthy and get you to pay 1,900 times what you would have to pay for it if you just turned on the tap. We have an incredible water system in this state. Actually, Providence has the second best rated water of any place in the nation. If somebody can sell this to you, and darn, I think we can sell the primary care trust.
All right, always an interest to many in our audience, but what can college students do to help make this a reality?
Talk to each other. talk to your parents, and talk to your legislators. Get this conversation going. You've seen something tonight that I think is invisible. Help them see it, because none of them have ever seen it before.
All right, last question. It sounds like we can create a healthcare system by building health centers next to every Dunkin' Donuts, or at least where there used to be one.
It's where there used to be one. There's lots to learn from Dunkin' Donuts and lots to learn from CVS, lots to learn from lots of people who have been able to effectively distribute products. Business modeling is very helpful to how we think about the organization of health services. But now we have to get them built and then, sort of find better things to do with the Dunkin' Donuts. They're a nice enough place, but there are better things we can do with the space. Great place for for stores that sell Rhode Island grown food. So with that, thank you all for inviting me. Thank you for being here. Oh, thank you. If you have a low tolerance for boredom, if you can stand a lot of boredom, we brought some copies of some of the data that we used in preparing this talk. So I think they're up front. You're welcome to them. We don't have enough for everybody, but if you're really interested and, like I said, tolerate boredom, please read what we wrote. Thank you again.